So, good morning, friends. Welcome back to Saturday Club of Baroda morning meeting. And today we have Dr. Sridhar Joshi. He had been our guest speaker earlier also, and he's very active participant in all the discussion, not only related to neurology, but other discussions also. So I'm always impressed with his vast repertoire of knowledge about many subjects other than his specialty, that is neurology. He is a consultant pediatric neurologist in Vadodara. He did his MBBS at Baroda Medical College, our alum. MD Pediatrics at Lady Hardinge Medical College, New Delhi, and DM Pediatric Neuro at CMC Vellore, a very prestigious institute. His areas of interest are neurodevelopment disorders, complex epilepsy, and pre-surgical evaluation for epilepsy surgery. And we had his talk few months back about treating complex epilepsies. And radiogenomics in neurometabolic and neurogenetic disorders, pediatric stroke, movement disorders, and neurorehabilitation. He has, to his credit, several presentations and publications, and he has his work experience as associate professor at CMC Vellore. Today, he is going to talk about a very unique subject. Many of us must not have heard about it, and that is radiogenomics. Genomics, we know, is a in thing, and a lot of talks we hear about genomics playing role in management and diagnosis. But radiogenomics, something very new to us. Radiogenomics, a new frontier in clinical medicine. That is the title of his talk. So, Dr. Sridhar, welcome back to Saturday Club. And you have about 45 minutes so to talk. We'll keep 10 minutes for discussion. So, over to you.
Sure. Thank you. I'll share my screen. So, am I audible and my screen is visible?
Clearly visible, clearly audible. Please go ahead.
Okay, so sure, we'll go ahead. So, topic has already been introduced. So, before we go ahead, what makes me eligible to take a neuroradiology topic? So, as we all know that I did my DM pediatric neurology from CMC Vellore, and our OPD timings were 8 a.m. to 2 a.m. I'm not done a mistake over here. It's 2 a.m. the next day, and it was 4 days a week. So in such a high OPD, we see a lot of patients of pediatric neurology, and all of those 70 to 80% of those do come with their neuroimaging to us. So we do see a lot of imaging also. Apart from that, we have a weekly multidisciplinary meet with pediatric neurology department, neuroradiology department every Tuesday, and once a month, common neuroscience radiology meet with adult neurology and neurosurgery department. Apart from that, I have also done 3-stage certificate course by Spin Academics, which is endorsed by American Society of Pediatric Neurology. So all in all, I have seen a lots of imaging and lots of pediatric neuroradiology experience. I am not a degree holder, but I am a trained pediatric neuroradiologist. So before we start, another question. Among the group, who feels that history and examination always leads to confirmed clinical diagnosis 100% of time? You can answer in the chest box, you can answer directly also. 100% confirmed clinical diagnosis. Or you can tell me an investigation in your practice from any of this above: blood, urine, CSF, plasma, stool, or radiology, in which pinpoints exact diagnosis of your patient, exact diagnosis, what we are looking for. Anyone? One investigation which pinpoints exact diagnosis?
I mean, we don't look at the patient like this. No, usually we have our clinical history and physical examination.
Yeah, so
and we go.
History and examination always leads to confirm clinical diagnosis. You agree to that, sir? 100%, always. What I can think of is peripheral smear. Sometimes it can give diagnosis of plasmodium, vivax or falciparum, leukemia. If the blast cells are more than 30%, then okay, leukemia also can be diagnosed. But if I ask you one investigation in your practice which pinpoints exact diagnosis, guides management, and also helps us explain prognosis to the patient, then that one investigation would be MRI brain. And today my goal will be to explain you how this investigation helps in these three things. So the scheme of my presentation would be to look at the basic MRI sequences. What are the clinical clues to imaging patterns? So as we all know, we will have the history first. We'll not be working like a radiologist. We'll be working like a clinical neuroradiologist. And then we'll see some cases where radiogenomics helps us in identifying the diagnosis and also prognosticate and manage the patient, and application for patient management of these patients. Okay, so this is a multiple part lecture series. We'll only be covering the few topics in the time allotted. So first sequence which we all should know is a T1 imaging. So T1 is lipid imaging, where it shows the anatomy perfectly. So the gray matter appears gray and the white matter appears white. This is the deep gray matter which has head of caudate, putamen, thalamus, and this is the lateral ventricle. So gray appears gray and white appears white, and usually contrast is done in T1 sequence. This is T2 sequence, which is water imaging. So as we can see, water, which is CSF, appears white on T2. So here, the gray matter appears white and the white matter appears black. So majority of pathologies usually appears white on T2. Any edema, infarction, swelling appears white on T2. So how I remember is basically stars are present both during day as well as night. But in night, we are able to see the stars. Why? Because the background is black. That's why we can say that, okay, on T2, pathology appears. So T1 imaging is anatomy imaging, T2 is a pathology imaging. However, there are certain T2 dark things which can be minerals or storage materials. Then flare again is T2 flare only. So the gray matter appears white and the white matter appears black. But here the fluid is attenuated. Which fluid is attenuated? CSF is attenuated. So CSF appears dark over here. This is used for any pathologies where we want to suppress the CSF signal. So periventricular ooze in TVME, and to comment on the pathology of cyst. So if it is a cyst with CSF filled content, then it will appear dark. If it is a cyst with non-CSF content, then it will appear bright on flare. Then few other sequences like diffusion weighted imaging and apparent diffusion coefficient. So these two imagings are for edema in the brain. So if the edema is present inside the cell, that is cytotoxic edema, it will appear hyper-intense on DWI and hypo-intense on ADC. Whereas if the edema is because of leakage from blood vessels, that is vasogenic edema, then it will appear hyper on DWI and hyper-intense on ADC. So what we need to remember when we say the word restricted diffusion, that means the water is restricted inside the cells. Whenever the water is restricted inside the cells, it will appear hyper-intense or bright on DWI and hypo-intense or dark on ADC. So DWI just tells us the presence of cytotoxic edema, and not DWI is equal to stroke, what we used to be taught in our MBBS tapes. So a DWI hyperintensity in a vascular territory is a stroke. But the DWI hyperintensity because of increased cells and the water content inside the cells could be a tumor such as lymphoma, could be a brain abscess, or could be a cytotoxic lesion of corpus callosum, which is abbreviated as CLOC over here. It can occur in multiple toxin or neurometabolic etiologies. So these two slides, I wanted to say that DWI hyperintensity is not equal to stroke. It could be seen in tumor, abscess, as well as other cytotoxic lesions. It just implies that we are dealing with cytotoxic edema or intracellular edema. And the last sequence which we all need to know is susceptibility-based imaging. So what is it susceptible? It is susceptible to detect minerals. So you can see all these black lines. This is nothing but the iron in the hemoglobin in the blood vessels. So this is normal susceptibility signals. We all have blood vessels in the brain. But if we have mineral deposition in regions of the brain, let's say because of bleeding, or let's say because of deposition of minerals in metal storage disorders, then we call them blooming on SWI. And it can also be used to detect calcification. However, we should remember that the gold standard for calcification is CT scan still. Okay, so revising all in one slide. So we have T1 image, which is for anatomy, T2 image, which is for pathology, FLAIR, where we attenuate the CSF, and which is to see the periventricular ooze, and to comment on the pathology of cysts and tumors, which are non-CSF filled. DWI and ADC are for cytotoxic and vasogenic edema, respectively. SWI is to detect minerals where they appear bloom. These are all axial sections of the brain. If I cut the brain in sagittal, then we can have a sagittal section, and I can also cut the brain from down to up, which is known as coronal section. So these are the few sections which we'll be seeing in subsequent slides with the cases. So before we jump on to diagnostic imaging, diagnostic radiogenomic patterns, I should introduce the audience to what is diagnostic imaging patterns and why it is important. So we will do that with help of two cases. First case is 12-year-old male with prolonged undifferentiated fever, weight loss, and since last 2 weeks has headaches and intermittent blurred vision. And since past 24 hours has new onset generalized tonic-clonic seizures and posturing. Whereas case 2 is again an adolescent male with headache for only 1 week and new onset left focal motor seizures. 2 episodes in last 24 hours and no clinical sense of raised ICP. So if we see the imaging of case 1, we can see supratentorial hydrocephalus, dilated lateral and third ventricles. We can see some ring enhancing lesions with perilesional edema in the brainstem. We can also see dilated fourth ventricle. In contrast, we can see this cluttered ring enhancing lesions in the basis pontis. We can see some meningeal enhancement. We can also see some edema of the spinal cord and a tuberculoma in the spinal cord. So this, and we can also see a shunt tube over here because this child had raised ICP, had to be shunted for hydrocephalus. So just by the virtue of imaging, we can tell that we are dealing with neurotuberculosis and the management would be ATT plus steroids with shunt placement for raised ICP and anti-seizure medications for treatment of seizures. Vis-a-vis case 2, which had only 1 week headache and left focal motor seizures, we can see again ring enhancing lesions with perilesional edema. But these lesions have a scolex. You can see this white dot over here in the FLAIR sequences. And because in T2, we can see it is filled with fluid. It is white. But on FLAIR, because this is CSF filled fluid or CSF intensity fluid, it is suppressed on FLAIR and we can see the scolex over here. And we can also see the ring enhancement. So just by the virtue of MRI, we could diagnose neurocystic sarcosis in this case. This is the scolex, which is seen better. And treatment, as we all know, is priming by steroids followed by albendazole and anti-seizure medications. So this is what diagnostic imaging patterns mean. So imaging, we can't get a microbiological diagnosis in all cases of TB and neurocystic sarcosis. But imaging clues helps us to get an early diagnosis, helps us to prognosticate the patient, and also manage the patient based on the imaging. So this will be applying to our cases. So we'll be going from clinomics to radiogenomics, which is an combination of radiomics, that is imaging patterns, and how that imaging pattern guides us to genetic diagnosis of the patient, which will help us predict diagnosis, guide management, and explain prognosis. So before that, how do we look and what areas do we look in the brain before we approach a case? We will have history and examination. We will not be blinded to history and examination because we are clinicians. So if I'm looking at a case of epilepsy or facial dysmorphism, I will be looking for the cortex. If I'm dealing with a case of movement disorders, I will be looking at basal ganglia and its connections. If I have a case with cognitive decline and behavioral concerns, then I will be looking at cortex, basal ganglia, and its limbic circuits. If I have history of fever, I will be thinking infectious or para or post-infectious etiology, in which I would be considering demyelination if there's a multifocality. If the history is out of proportion, let's say loose stools for 3 times and severe metabolic acidosis clinically, then or if there is a positive family history, microcephaly, skin and hair abnormalities, I would be thinking it is a genetic etiology. If it is an hyperacute onset unilateral deficit, I would think as a vascular etiology. And if it is a tone abnormality, I would be looking at corticospinal tracts, basal ganglia. And for eye movements and brain's bulbar symptoms like loss of gag reflex, swallowing difficulties, dysphagia, dysarthria, then I'll be looking at brainstem to find out the pathologies. And even with this, I still need to know my patterns because we always have to be ready for surprises. So let's dwell into this world with few simple cases first. The first case is a 7-year-old male with intellectual disability, autism spectrum disorder, and has polymorphic seizures. He has focal seizures with epileptic spasms, despite 4 anti-seizure medications. I give you the examination findings, and he has Ashleaf macules on trunk and adenoma sebaceum on face, which are facial angiofibromas. So no guesses for this. All of us know that we are dealing with tuberous sclerosis over here. But then how does imaging help us guide further this patient? So here you can see this area, you have a large dysplastic tuber. Tuber is nothing but a dysplastic area of cortex where the gray-white differentiation is not maintained. So we have a large tuber. We have also subependymal nodules, and we have this flimsy white matter bands, which are migrating radial bands, as we call. And this all tubers as well as subependymal nodules are calcified, as we could see on CT scan. Now, how does this information help me? So let's see the natural history of tuberous sclerosis. Majority of them present in the first 10 years of life. And if you have large cystic tubers with dysplastic centers and abnormal white matter, what we had in our case, we suspect that this could be a TSC2 mutation. They're commonly associated with intellectual disability and autism spectrum disorder, and they have multifocal seizures and spasms, which are poorly localized on EEG and clinically, and they are often drug and surgery resistant. So just by the virtue of imaging, I can tell that this could be TSC2 in majority of cases, associated with ID, epilepsy, which is drug resistant, and they would not be amenable to surgery. Whereas if I would have a thin, wispy bottom of sulcus tubers, which are very thin, then I would think of a TSC1, and they are amenable to surgery and they are also drug responsive. So thus, by the virtue of imaging, I could tell my parent that this child won't respond to drug which we are giving. So we were giving him valproate, levetiracetam, clobazam, and topiramate, but he was not responding. So then parents ask, what next? If not surgery, what can we do? So then we have this study where everolimus has been tried for treatment refractory seizures in tuberous sclerosis complex, because everolimus is an mTOR inhibitor, and tuberous sclerosis complex does have overregulation or upregulation of mTOR pathway. And we started the child, and child has been currently seizure free from last 1 year. And this existing trial shows the similar things, that TSC2 patients or tuberous sclerosis patients with drug refractory epilepsy treat with adjunctive everolimus, and it leads to sustained reductions in seizure frequency. Currently is on only 2 drugs, valproate and everolimus. So this is how we can help. So this is what radiomics, that is clinical imaging pattern, helps us predict genomics, that is the TSC2 gene mutation, and subsequent management as well as prognosis. Now I cannot tell the parent that I can cure this patient permanently, but with drugs, he can have seizure reductions and improve the quality of life. Second case on similar lines, 3-year-old child with recurrent left focal status epilepticus on 5 ASMs. Still the seizures are not going. Examination wise, port wine stain on right hemiface. So again, a clinical pointer. Any clinician or pediatrician who has seen such cases can make easily a diagnosis of Sturge-Weber syndrome in this child. But now, how do we apply that clinical markers in radiology and genomics? So as he has left focal status epilepticus, and as I told, if we look at epilepsy, we have to look at the cortex. So we can see a thinned, shriveled cortex on the right side, which is atrophied as compared to the left side. We could see some leptomeningeal vessels on the flare. We can see an enlarged right eye as compared to left eye, which could be because of glaucoma. And on susceptibility weighted imaging, we can see these vessels forming a leptomeningeal angiomas. On contrast, we can see these vessels easily light up on T1 contrast. So this is what we call a tram track or an IV sign. And we can also see an ipsilateral dilated choroid plexus. So here we are dealing with a right-sided leptomeningeal angiomatosis with ipsilateral dilated choroid plexus. And another important sign which we should all look. Whenever we look in Sturge-Weber syndrome, all of us look at the leptomeningeal enhancement. But what we need to look is this enhancement around the brainstem. That is the midbrain, the perimesencephalic system. If this enhancement is unilateral, then we can predict that the leptomeningeal angiomatosis will also be unilateral. However, if this enhancement is bilateral or a W-shaped enhancement of the interpeduncular system, then we can predict beforehand that this leptomeningeal angiomatosis will become bilateral in future. So this case C was referred as a case of unilateral Sturge-Weber syndrome for surgical excision. However, because this W-shaped enhancement was found in interpedunculaire cistern, which these two authors described under the name as a warning sign of Warnay-Mankad. So if we see a dual enhancement in interpedunculaire cistern, it is a predictor of bilaterality in Sturge-Weber syndrome, and this will not be amenable to surgery. The case I showed previously was unilateral. It had unilateral enhancement of the interpedunculaire cistern, as we can all see over here. This is a vessel, but the enhancement is unilateral. So this case would remain unilateral, and this case was operated with peninsular hemispherotomy and is currently seizure-free without medications. Sturge-Weber syndrome, we have been taught that it's an autosomal sporadic inheritance. However, it can also have genetic mutations. And if it is a unilateral thing, as predicted by the unilateral enhancement, options would be surgical. So how do we apply clinically? We all know it's Sturge-Weber syndrome, but management-wise, if we see a bilateral enhancement, we tell that parents that it cannot be excised surgically. We have to give drugs. Normal drugs are failing. So now the research is saying that this also has hyperactivation of MAP kinase and mTOR pathways, and current drugs activating these pathways can be useful. So we are trying vigabatrin, which is inhibiting mTOR pathway in these patients with Sturge-Weber syndrome, but other options are still opening up. So I hope with these two cases, diagnosis is not difficult. Clinical diagnosis is easy, but MRI guides us prognosis and management options for the child. So this is what we call clinical radiogenomics. So now we'll go with further cases. 6-year-old child, fever with gastroenteritis, generalized convulsive status epilepticus, followed by coma within 24 hours. Blood culture, Salmonella typhi positive, pediatrics team started dexamethasone, suspecting enteric encephalopathy. However, no response. The child remained comatose, had to be intubated, and had convulsive status epilepticus and also non-convulsive status epilepticus on EEG. That's when we were called and we asked for imaging. Usually when we ask for imaging, the pediatric department are very skeptical because these patients are vitally hemodynamically unstable and they feel that imaging will not tend the management. But see what we found in imaging. You can see bilateral thalamic hyperintensities. They are swollen and they are compressing the third ventricle. You can also see hyperintensity on DWI and hypo on ADC, which is called cytotoxic edema, which is also seen in the cerebellum. You can see blooming on SWI in both thalami, which is because of bleeding in the thalami. And you can see multifocality, involvement of the deep gray as well as cerebellar white matter. Had this MRI been not done, this child would only have received dexamethasone and supportive care. But this MRI features of swelling in bilateral thalami with ring-shaped diffusion restriction and blooming on SWI is classical for something which we now call acute necrotizing encephalopathy of childhood. And they do have this classical gray, deep gray involvement with this classical trilaminar necrosis, which has center of hemorrhage, as we also blooming on SWI, a rim of cytotoxic edema, which is dark on ADC, and a rim of vasogenic edema, which is bright on ADC. So if you see ADC sequences of this patient and this trilaminar necrosis is classical for ANEC, that is acute necrotizing encephalopathy of childhood, and it is in para-infectious hypercytokinemia syndrome. So this is the diagnostic criteria. It is basically because of innate immunity dysfunction and cytokine storm, and cytokines like interleukin-6 are elevated in these conditions, which breach the blood-brain barrier and cause this intense neuroinflammation in this case. And what is the genetic implication? These patients can have recurrent such neuroinflammatory states with another infection. So if this child develops influenza in future, again he might have these things and he can become comatose. Okay, so because it's an recurrent thing, it is caused by gene of RANBP2. It's a cytoplasmic surface protein on the nuclear pore, and it has its main function is in intracellular trafficking and energy maintenance. So not all children with Salmonella typhi will have this, but the ones who are harboring mutation in this gene will have hypercytokinemia, innate immunity dysfunction, and it will lead to hyperinflammation, which leads to severe phenotype in these cases. Now, how this is useful? This is useful in treatment. This child requires interleukin-6 receptor blockade by tocilizumab. So, if this child imaging helped us to give early diagnosis, we treated the child with tocilizumab and the child recovered completely. So, you can see these literature cases where within 5 days with tocilizumab, you can see the clearance of the edema in the thalamus as well as the brainstem. And within 2 months, the MRI is completely bang normal. So this is what we call infection-triggered encephalopathy syndromes. So there are some 5 or 7 syndromes, but of them, we need to remember that only acute necrotizing encephalopathy of childhood, which is bilateral symmetric thalamic lesions with triangular necrosis, multifocal gray and white matter lesions with brainstem involvement, is a genetic etiology, and it can reoccur if the patient harbors RANBP2 mutation and the treatment is early tocilizumab. No other supportive treatments would help these children. So again, any acute febrile encephalopathy, status epilepticus, that's why we push for imaging as early as possible, because if we identify these patterns, this helps us in early diagnosis and management with drugs which would otherwise not help an infectious etiology. These are other few IT syndromes which we also usually encountered in clinical practice. And in all these things, again, we have to give steroids and other cytokine, anti-cytokine therapies. So this we should all know. Going further, we have a 6 months female born to 3rd degree consanguineous parents who presented with failure to thrive, recurrent fever, and status epilepticus. On examination, she had silvery blonde hair. Elder sibling died at 1.5 years. And that child was a male child. He also had failure to thrive and recurrent infections. So because now in history, I have something which is consanguinity and positive family history, I would think genetics. Because I have failure to thrive, recurrent fever, status epilepticus, I would look for any infectious or a para-infectious etiology, and I would look at the cortex. So here we can see that the cortex is swollen multifocally, temporal, insular is swollen. You can see the left motor cortex as well as sensory cortex is swollen. Bilateral thalamic swelling, brainstem is involved, midbrain, pons is involved, and you can also see blooming over here. This means there is a bleeding in the brainstem. And you can also see dirty white contrast enhancement, which means the vessels are leaking out. So here it is a multifocal thing, and what I call this as full house pattern. All the sequences are showing abnormalities, whether it be T1, T2, flare, SWI, DWI, everything shows an abnormality. So when you have abnormality in all the patterns, this is what is classically seen in extensive neuroinflammation. And this pattern with the silvery blonde hair, and if we do a hair microscopy, we can see this irregular large melanin clumps. This is classical for an CNS hemophagocytic lymphohistiocytosis syndrome known as Griscelli syndrome. And yes, genetics was done, and it was a RAP27A gene, which was autosomal recessive and a pathogenic mutation for Griscelli syndrome type 2. Now, how did the imaging help here? Because we were aware of the clinical history and the presentation, and this imaging, which is what I call a full house pattern, is classical for CNS HLH. That's why we ordered a skin microscopy for this child. Skin microscopy showed these findings and genetics was done. Now, based on this radiomics and genetics, we have diagnosed that this is a case of monogenic HLH, which is primarily a T cell and a macrophage-driven hyperinflammation syndrome. It has 2 imaging patterns. Lesion, pattern 1 is lesion positive. As
Are you all able to hear Sridhar, or we have lost his connection?
No, not able to hear.
Okay.
So what is pattern 1? They have multifocal demyelinating lesions. You can see again full house, flare as abnormality, T1 as abnormality. It has abnormality of both
Sridhar,
supratentorial.
sorry to interrupt you. For a few minutes, half a minute or so, your connection was lost. So if you can repeat the last slide again.
Okay, where? This one?
Yes, positive and negative lesions you're talking about.
Yeah, sure. So based on this history, we diagnosed and imaging, we diagnosed this child as CNS HLH. So I am discussing few slides on CNS HLH and how this pattern of imaging guides to genomics and guides diagnosis, management, and prognosis. So the lesion positive is pattern 1. It can have these 3 patterns, which we will be discussing in subsequent slides. However, we can also have imaging negative phenotype, which is only non-specific. It can only show atrophy, which is pattern 2. Pattern 1 usually is amenable to treatment and has a 2 times higher chances of deficit-free survival, whereas lesion negative phenotype has a lower chance of survival. So this is a paper from our group and the Ghosh group when I was in CMC. So pattern 1 is lesion positive. Here you can see multifocal demyelinating lesions, both supratentorial as well as infratentorial. They can have various kinds of contrast enhancement, nodular enhancement, or targeted enhancement. You can also have involvement of the cauda equina nerve roots of the cranial nerve 7, of the optic nerves over here. So this is what we call pattern 1, multifocal cerebral and cerebellar involvement with brainstem and cranial nerve involvement. So this is pattern 1.1. Pattern 1.2 is isolated brainstem involvement. In brainstem also isolated pontine involvement. So this is what is PONS. So this pattern is called as CLIPPERS. CLIPPERS stands for chronic lymphocytic infiltration with pontine perivascular enhancement responsive to steroids. So before this disease was diagnosed as monogenic HLH, these patients underwent brain biopsy. And in brain biopsy, they saw that the PONS has a very chronic lymphocytic infiltration, and the imaging shown pontine perivascular enhancement. And when steroids were given to this patient, they would respond transiently, but not completely. So this was named as CLIPPERS. Now, if you see this pattern in PONS, this dirty white pontine swelling with contrast enhancement, you know that this pattern is an CNS HLH pattern. And the pattern 3 is cereballitis pattern. You can see diffuse cerebellar swelling, which is causing upstream hydrocephalus, and over the line from December 2016 to November 2017, we can see this has undergone severe atrophy. This is pattern 1.3. Now, why it is important? Once you diagnose this child as CNS HLH, they're amenable to hematopoietic stem cell transplantation. So those with familial HLH, that is our case, have higher up to 70% chances of survival after hematopoietic stem cell transplantation, and majority of them have complete remission. 80% of them have complete remission with hematopoietic stem cell transplantation conditioning. So this child, second child, underwent a hematopoietic stem cell transplant and is currently 2nd year in his survival, and she is doing well. Here also, if we had not got that imaging clues, we would have not have thought the genetic clues, and both imaging and genetics together gave us that this is an amenable condition for treatment, like previous cases. This is another case, no history I have given. This I want entire group to know. If you see, and all the pathologies which we saw previously were T2 pathologies. This is the only pathology in entire pediatrics which is an T1 pathology. So if you see a T1 bright corpus callosum, a T1 bright midbrain, dorsal pons and medulla with the cerebellum white matter with spreading of ventral pons, and a T1 bright globus pallidus, until proven otherwise, this is almost always hypermagnesemia, hypermanganesemia, not magnesium, manganese. So this is a metal storage disorder. So you can always predict the clinical symptoms over here because you have involvement of globus pallidus. These children would present with dystonia. Okay, so this is again a largest cohort from CMC Vellore, where my guide Dr. Sangeeta Yoganathan was one of the key authors. So this was 27 children from over India, majority of our Indian authors. And this was the classical finding. They had 2 types which are described. Type 1 hypermagnesemia with dystonia, and type 2. Usually type 2 patients have earlier age of onset as compared to type 1 patients. And all of them present with gait abnormality, Parkinsonism symptoms, and they have higher manganese levels. Now, why is this pattern important? Because if you see a T1 bright globus pallidus, you think hypermagnesemia. You think hypermagnesemia, you think that it's a genetic etiology. And when you think it's genetic etiology, you do genetics and you treat. And these patients are treatable with chelation therapy with calcium disodium EDTA. So again, clinical history, gave a radiological clue. Radiological clue gave us a genetic clue, and genetic clue gave us a diagnosis, prognosis, and management. Now, this prognosis is this type 2 hypermagnesemia with dystonia are poor responders to chelator therapy, and type 1 are good responders. So if you see a majority, if we start chelation therapy, out of this 27 children, 9 demonstrated some improvement, 3 stabilized, and 2 had marked improvement, and 1 had normalization. So this is almost around 3/4 of cohorts which improved with chelation with disodium calcium EDTA. Okay, however, the type 2 ones with SLC39A14 gene had poorer response, and 2 children died and 9 were lost to follow-up in this cohort. So that's why, again, imaging guides diagnosis, management, and prognosis. Few last cases. A 10-year-old adolescent boy presented with tremulousness of limbs and abnormal twisting postures of upper limbs, which is nothing but dystonia. Examination-wise, he had classical bilateral KF rings, dysarthria, dysphonia. We all know KF rings is equal to Wilson's disease. But now, how does imaging guide us? This is a child with Wilson's disease, we all know clinically. But if you see these flare sequences, you can see the center is dark and the periphery is bright. So this is what we called as striatal necrosis. Caudate and putamen has undergone necrosis, which is hypointense in the center and dark in the periphery. Whenever you have striatal necrosis, and if you start, and this DWI is showing some diffusion restriction, you can see the caudate head is bright on DWI imaging. This is cytotoxic edema. If you have this imaging and if you start a copper chelating agent like D-penicillamine in this child, these patients will have worsening, which is known as paradoxical worsening or D-penicillamine related worsening, leading to status dystonicus in this child. So you can see this child, you can see this child, they're crying in pain, all the muscles are stiff, tight, and dystonic. You can see this child is completely dystonic. So we stopped D-penicillamine and we started on child on triantine and zinc. Ultimately, triantine was not affordable, so only zinc monotherapy was given, and the child was given copper-free diet. With that, now the child is walking around and now also cycling. So in April 2022, he was having NG tube in C2, but by June 2023, no NG tube. He's walking around, cycling, and going to school now. Again, Wilson's disease is not a rare diagnosis to make. It's a good diagnosis to make. You can make it clinically also. But if in imaging, if you have striatal necrosis and diffusion changes, do not give D-penicillamine to these children. Just give zinc monotherapy and copper-free diet, and you can see changes, but it would be occurring over years. So it took from May 2021 to June 2023, almost 2 years for this child to receive normalcy. Had these parents not been given hope, this child would have ended in neuro rehab center.
No voice.
Again, it seems we have lost him. Let's see. I'll call him.
Did I?
Yes.
Again?
Yeah, you should. That slide we showed the child cycling, no?
Yeah,
There
yeah.
we stopped, yeah.
Yeah, 1 minute. I'll reshare again. Something is. And now I think it's visible.
Yes, but I think you will have to go to the previous slide. I think you're talking about.
Yeah. So basically, that child was given. That child was a case of Wilson's disease. The imaging was visible. No? Imaging was visible.
Imaging, we saw everything you
Yeah.
talked about, his
Yeah, so-
improvement after therapy. Yeah.
Yeah, so the child was having Wilson's disease. Imaging was showing striatal necrosis, and there were DWI changes also. So in those children, D-penicillamine is contraindicated as it can lead to clinical worsening. And this child had status dystonicus. So we shifted him to zinc monotherapy and triantine for few months. With that, he had a gradual improvement, and from May 2021 to June 2023, that is almost over 2 years time. Now this child is cycling, going to school, doing all his activities by himself. So again, it's a genetic disease. We all know Wilson's disease caused by ATP7B gene mutation. Clinical diagnosis is okay, but MRI gives us a clue to further guide the treatment and the prognosis of the child. So this MRI had a clue that do not give D-penicillamine. This child was treated at Ranchi with D-penicillamine, came to us with status dystonicus in this severe state. We had a very difficult time managing this case. He required 7 antidystonic measures with continuous midazolam infusion, Botox, and all those things. But it took the parents were distraught with the condition. But with hope and a good chelation with triantine and zinc monotherapy with copper-free diet, the child is doing well currently. These are other disorders which we call as neurodegeneration with brain iron accumulation. Just to finish the metal-Surette disorders, this also can be diagnosed based on clinical symptoms and imaging patterns. I will not go in detail of the imaging patterns, but one which we should all know is this eye of tiger sign, which is classical for PKAN, which is pantothenate kinase associated neurodegeneration. This patients present with dystonia or chorioidosis and pigmentary retinal degeneration. Why it is important? Because if we diagnose this eye of tiger sign, now the trials are going on for iron chelation therapy in the brain, and these patients can improve with that. So these are the metal-Surette disorders. Now we'll lead to multi-system disorders. So this is a 16-year-old child, again from our center, CMC Vellore, 4 months history of sensory ataxia in upper limb as well as lower limbs. So because he was having sensory ataxia and he was having absent proprioception and vibration, he was suspected to have a lesion in the posterior column of the spinal cord. And he was also having failure to thrive and was having recurrent wheezing in the chest. So MRI was done. As expected, posterior column is involved. As we can all see, this inverted V-shaped appearance of posterior column. We might have seen this in subacute combined degeneration of spinal cord in B12 deficiency. Because he was having chest signs, chest CT was done, which is showing bronchiectasis in this child. However, there was no TB in this child. So this was a case of subacute combined degeneration of the spinal cord. However, clinical history revealed that the child had recurrent sinusitis and has undergone functional endoscopic sinus surgery and is also a history of chronic cough. So clinically, he was suspected to have disease involving lung, sinuses, failure to thrive, malabsorption syndrome, and now a neurological involvement. So he was suspected to have a cystic fibrosis. So MRI was done, and MRI did show pancreatic atrophy for this child. Most common because we see subacute combined degeneration causing this MRI findings. B12 was done and methylmalonic acid was done, which were normal, and then CFTR gene, which came out to be positive. So if you see a subacute combined degeneration of cord, that means if you see a posterior column lesion, apart from B12, also think of deficiencies of vitamin E, copper, and nitrous oxide anesthesia. That is rare, but vitamin E and copper deficiencies are very common and which can lead to this dorsal column involvement in children. So a dorsal column involvement can guide us to have nutritional, metabolic, or toxic causes. And in this case, it was actually a genetic cause like cystic fibrosis, which caused malabsorption of fat-soluble vitamins, vitamin E deficiency, and vitamin E deficiency leading to subacute combined degeneration of spinal cord. So this was a case. Now going to vascular spectrum, 7-year-old child with recurrent TIAs. However, again, family history is positive. Okay, recurrent TIA. So we'll think vascular. So we'll see the vessels. So here again, we can see leptomeningeal slow flow vessels, which is known as IV sign. We can see diffusion restriction, but you see this diffusion restriction is not in a vascular territory. It is in a territory which is involving both the anterior cerebral artery as well as middle cerebral artery. So which is what we call as watershed territories. Here also you can see diffusion restriction in territory involving MCA and the posterior cerebral artery. So this is again a watershed territory infarcts. So whenever we have watershed territory infarcts and we do a MRA, that is magnetic resonance spectroscopy, we can see thinning of the distal internal carotid artery, and we can see this puff of smoke appearance. So this is classical for Moyamoya disease. Now we all know Moyamoya disease, but what this child had? He had an elder sibling which had similar history. So we think genetic moya moya. And this child had RNF213 mutation, which is very common in South Asian ancestry, which predisposes the child to familial moya moya syndrome. So this was a child of RNF213 mutation related moya moya. These children don't respond that well to vascular surgeries as compared to the children who are non-genetic. Okay. Again, a child with intellectual disability, strabismus and progressive scoliosis on examination had horizontal gaze palsy. Here there are some findings like butterfly medulla, a pontine cleft, and he had this what is called as scoliosis. Here the diagnosis was made on clinical basis. He had horizontal gaze palsy and he had progressive scoliosis. So the diagnosis was horizontal gaze palsy with progressive scoliosis, which is caused by mutation in ROBO3 gene. Okay, so here you can see vertical eye movements are preserved, but the horizontal eye movements are absent, and he has a scoliosis which has been surgically modified. So if you see a child with horizontal gaze palsy and progressive scoliosis, think of ROBO3 gene mutation, and you can see these findings of butterfly medulla, pontine cleft, and scoliosis. Okay, so this were the few cases. So my take-home messages are: know your anatomy well, recognize the patterns, and think like a clinical neuroradiologist. This is a QR code of all the articles which I have mentioned. You can scan this thing and get all the articles in your Google Drive link. Okay, so this was my presentation. I would be happy to take any questions if are there. I hope I made little sense to the clinical radiogenomic spectrum. Thank you.
Thank you, Sridhar. Now you can stop the screen sharing. Yeah. So it made a lot of sense, not little sense. It made a lot of sense because the title itself was a little catchy. Now I understand that it's not about genetic study only. You are using radiology as a tool to lead to a very specific, precise diagnostic, genetic studies. So wonderful. I mean, all the techniques were so good. And it made all the difference in the management also, as you demonstrated that Wilson was really awesome. So it's open to questions now or comments. Anybody who has any questions?
No question. It is excellent talk. Lot of learning. Sridhar,
Thank you. Thank you, sir.
CMC Vellore is great.
Yeah, all the cases.
Yeah,
We are all very happy that Sridhar has decided to settle in Baroda.
that's what he brought CMC here.
Yeah,
he brought
that was the
CMC.
aim. That's what my teacher told me. That if a patient comes from Baroda to Vellore, then you're not doing justice to them. They should not be referred from Baroda at least.
Good, good. And now that all facilities for investigations are also available, so that makes the life easier.
Yeah.
Yes. Any other comments, questions? Is somebody from your group here? Nivasi Nair, I don't know.
Yes, yeah, they are residents, KGP residents.
Achha, KGP resident. Okay.
Hmm.
So I think there are no comments or questions.
Satish bhai,
Look at the yes.
congratulations, Sridhar,
Thank you, sir.
for an excellent talk. Because my brother-in-law in California have combined with neurophysiologists and neuroscientists to form a AI company called Rapid AI. You can go to their website where MRI AI is used in for fast diagnosis for people where MRI is not available. The diagnostic expertise is not available. My question is, you have talked about MRI.
Yeah.
But which are the, like T1 image you said, that manganese deficiency can be caught only on T1.
Yes.
My question is there any disease which can be caught only by PET scan or a molecule specific nuclear scan?
Yeah, so we do have this thing. We see lot of paraneoplastic syndromes called, one of the common which we see is opsoclonus myoclonus ataxia syndrome. In less than 5 years old, they are usually associated with the neuroblastoma. But sometimes the neuroblastoma is so subtle or which is not picked up on MRI or CT scan of the thorax and abdomen. In that patients, if we do a DOTA type PET scan that has somatotropin molecules, the neuroblastoma picks up that thing and it lights up on PET scan. So we have had case just a few months back, which was classical opsoclonus myoclonus ataxia. I was suspecting a tumor, CT scan normal, MRI normal. Then we collaborated with Dr. Urvinder Kaur, who is our pediatric hemato-oncologist. We did a PET scan and the PET showed a light up tumor. Then we went back to CT MRI and then CT MRI. Then the radiologist told that, yeah, we can see something. Then we explored the child and there was a neuroblastoma of 2 centimeters in the para-aortic region. We removed the neuroblastoma and the child became 50% normal just by that removal, and other 50% currently is recovering with our immunotherapy. So yeah, there are diseases which can be picked up on PET scan, but usually what we do is they are picked up on MRI, but if they are metastasizing to other organs like bones or vertebral column or long bones, then PET scan can give us the spread of metastasis also sometimes. So there may be only single primary which can be seen on MRI, but PET scan can give whether they are metastasized or not. That is one of the other things which we should use.
No, because metabolic imaging is a topic altogether.
Yeah, it's a topic altogether. But in pediatrics, still we are happy with MRI. But yeah, we do use PET scans. In our epilepsy surgery cases also we use, whether the other cortex is functional or not, to see that we use PET scan, or the cortex is abnormal, does it show hypometabolism in PET, to tell that this is already destroyed. So removing that would not make any further damage to the child or the patient. So metabolic imaging is coming up in a big way and is the future. I do believe that. And a precise
Today-
metabolic imaging.
Today is 12th July, World Day of Hope, from organ donation to scientific diagnosis. So we have learned a lot today. But I hope that the investigation changes the quality of life and the management
Yeah,
after
is
the
what,
imaging and diagnosis.
Diagnosis. That's what the main aim is.
Yes.
So tuberous sclerosis anyone can diagnose, but to tell parents that okay, you don't have a surgical option and only a medical option, and to find those therapies by doing a randomized controlled trial, that's where science lies. So science is to serve society. So we should not stop learning. Till the time science is there, society has to thrive. So, and that is how we all have to collaborate, physicians, surgeons, and our viewpoint should also be collaborative. So we should be looking at history, examination, investigations, and then a diagnosis, guide management, and prognosis of the child. So that's what we are all hoping for.
Very well said. Sridhar, talking about artificial intelligence, the same thing which you presented, can AI help in this pathway of diagnosis?
Yeah, it can help. So the artificial intelligence has two things. One is generative AI and one is a part which is known as machine learning. So what we can do is, if I feed 100 scans of a disease to that machine, the machine will learn the pattern. After that, if you give that pattern, the machine will tell this is the thing. The only thing is there are mimics of each and every part of this. So mimic part, it will still be required, but that's what they say. The radiologist using AI will replace radiologist not using AI. So AI will fast track these things. But my point of view is usually MRIs are delayed for these children, thinking that it will not give them further things. सब तो कर लिया, ceftriaxone, vancomycin, acyclovir, ATT steroids, everything has been given. अब MRI करके क्या करेंगे? That is what I usually hear when I go to cases. But that's what MRI can tell. If it is an ANAC, even if it's Salmonella typhi positive, the treatment is interleukin 6 receptor blockade and not dexamethasone. That's how MRI can help over here. So the thing was, okay, if you are thinking that it's an MRI animal disease, do a early MRI and change the life of the treatment. That's how we wanted to.
So all these modalities that you initially started your talk with, I mean, are all patients subjected to all the modalities, or we as clinicians have to guide them that do this, do this, do this?
So no, it is that's what I told. I'm a clinical neuroradiologist. I like to call myself a clinical neuroradiologist. So I take the history, and based on the history, I know it's a Serge-Weber syndrome. Now my goal is to tell that this Serge-Weber syndrome is it amenable to surgery or is it amenable to only medical therapy? I can only tell this based on that W-shaped enhancement or the Warnay-Mankad sign. If I see that,
I was asking about the radiologist. When I refer a child to a radiologist for MRI, I mean, as a clinician, I have to tell them that do this particular film? Like say you describe some 5 or 6 types of.
Yeah, so that
using
all they
it
do,
in a
it is standard. All these films are done usually.
Okay.
It is a standard radiology practice to do all these films. MRI brain will include all these sequences: T1, T2, FLAIR, DWI, ADC, and SWI.
Okay.
Angiography is something which we'll have to ask for. We have to write MRI brain with MR angiography when we suspect vascular deficits at that time. So if you have recurrent TIA or if you have unilateral hyperacute unilateral onset hemiparesis, then you suspect vascular. At that time, we have to refer to radiologist saying do a MRI brain with MR angiography. Then only they will do. Otherwise, they won't do. And if MR angiography is not done, you might miss moya.
Right.
Either fetal
Yes, sir.
medicine and 4D sonography has gone into identify neural tube defects, even gastrointestinal tube defects.
Yeah.
Last week only I had a case of anorectal tube defects in feto. So
Yeah.
has it changed in your branch 4D sonography?
The last 1 month, I have seen 4 cases of fetal neurology, and I'm happy to say that I have prevented 3 abortions because this is my another talk of interest, fetal neurology. It's an evolving field, and I'm very much interested in it. So what happens is, as soon as they find ventriculomegaly on a 4D scan, there is a panic button in obstetricians. They are something like they think that some neurodevelopmental disorders will occur. When you find any fetal abnormality pertaining to brain and any other part of body, please do refer to us. We know the neurodevelopmental prognosis. Okay, so we can guide parents as to how we can change the trajectory of their life postnatally. What is happening is some scan 4D sonography is done. They say some abnormality in the brain, let's say cisterna magna cyst or a cerebellar hypoplasia, and the parents become hopeless that okay, we got a child which is abnormal. It's not like that. Some of them do grow up to be very normal children in future. So that's what we are. I have seen 3 patients last month only. Very precious pregnancies in their 30s and 40s they were having, and just because of one finding they were told for abortion. They came to consult. I told it is not a problem. We'll do the scan after a few weeks, and few weeks after the scan showed a regression of ventriculomegaly in the child. Now they will go for deliveries in future. So yeah, fetal neurology is an upcoming talk. I would like to talk more once I get more patients of that, and I'll talk on this forum about fetal neurology. But yeah, it does help. So I do see fetal scans also now. That is upgradation in my
Good.
thing.
We
career.
also avoided one abortion in an anorectal tube defect when we confirmed the second opinion that anorectal is a very low defect and it can be cured by a simple anorectal surgery after the
Surgery, yeah.
delivery. So that lady, my niece, was very grateful that we could advise her that take a second opinion of a pediatric surgeon standing while 4D sonography was being done.
Then yeah,
My
that's what. So
question
that
was
is
postnatally, when the
Yeah.
child is already there, do you use 4D sonography? Because in our own children hospital, we had a study by Jayesh Shah and all that to do brain sonography through Fontanelle many years back.
Yeah. So no, I'm not trained to read ultrasound, but and 4D sonographies also I have seen only prenatally. Postnatal 4D sonographies I'm yet to see. I have not seen them, so I may not be the right person to answer this. But yeah, we do use 3D for sonography in KGP, where we do find intraventricular hemorrhage and abnormalities like that. But it can be done, and till the time Fontanelle is there, anything can be done through Fontanelle. Even if Fontanelle is not there for sickle cell disease, we do this transcranial ultrasound, and based on the velocities, we do guide their treatment. So yeah, radiology is helpful. If your velocity of MCA is more than 200 centimeter per second, they are candidates for hydroxyurea in sickle cell disease. So that is transcranial ultrasound without Fontanelle. You just put the probe in the orbital region or the temporal region and just find the MCA vessel velocities. So can be done. I have not seen 4D, at least in postnatal period.
Okay. So I think it's exactly 9 o'clock and time to end the session. Thank you very much, Dr. Sridhar, for being with us. And thank you all the audience for very interactive discussion. So we meet next Saturday morning again, and we'll have Dr. Kiran Shah. I'll share the flyer shortly. So thank you all. We meet next Saturday again. Thank you. Thank you.
Thank you.